Marie, et moi je l'appelais Maria. Elle s'appelait Marie, et moi je l'appelais Maria. C'est elle que je veux, et c'est elle que j'adore. C'est elle que j'adore. Elle s'appelait Marie, et moi je l'appelais Maria. Elle s'appelait Marie, c'est elle que je veux, et c'est elle que j'adore.
Yourself to them, okay? So while the music is going, let us see you introduce yourself to your baby, to your friend, to your neighbor, that person you just met here today. And as we said before, we are very happy to be considered as such. We are so happy to know that in our midst we can recognize the presence of the state representative.
Wow, that's amazing. I can see my son drew it to me on Father's Day. Really? Wow. Yeah. That's amazing. A lot of life in that.
So related to welcome our former chief of police from Lowell in the person of Mr. and his wife, Mrs. Lowell. So Mr. and Mrs. Lowell, in the presence of Mr. and Mrs. Shapiro. Thank you, Mr. and Mrs. Shapiro, for showing up. And as we can see, we can all walk to that center stage. We had originally prepared it as a high table, but we saw that that is the best place for us to showcase our culture. When you take a good look at our backdrop at the door, you have not seen the few of the things that are displayed on that table. It's a very rich table. That table is what we can call a microcosm or a melting pot of the Ngemba land. Go there, you will discover the delicacies that are served. And I just wish to indicate that in the course of our evening's program, we will give the pride of place to the most cherished dish of meal. The table where we have the display of the magical productions, the magical fruits of the spirit, imagination of the Ngemba land. And today we will be savoring it big time.
We have roasted cocoyam. This is pumpkin pudding. Yes. make this pudding. Yes. So we use this seed. We have two kinds. This.
I see.
This and this. These are pumpkin seeds. So we blend it and then we make it into a mold.
That's amazing.
Yes.
Oh, wow.
We don't have aluminum foil.
That's with banana leaf.
Oh, see that? Yeah, that's
Yeah.
right. Yeah, man. That's how we use it. Banana leaf, right?
Yes, that is with banana leaf. Yes. This one is with the green pumpkin seed. So that's pumpkin. Yes. Yes. So the seed comes from inside. So all of these are things we use to eat this. You make all of them? Several people make them. This one is
Can we put our hands together for that? This occasion a success. And when the president was leaving, she said, we must recognize him as there is the advisor. He's the advisor to the Ngemba people. They are the rocks, the roots. And Tata Fobanjong, Dr. Fobanjong, he is always hiding. That's the advisor number one. He's always hiding, but you cannot light a lamp and hide it. Over to you, my father.
Thank you very much, MC. You have been so eloquent and you have uplifted our spirits tonight. Thank you very much. I stand here on the shoulders of those who have worked very hard. Those accolades that you have thrown on me, I share it with so many people because I couldn't do it alone. And I am standing on the hand that are holding me, so I don't do anything alone. So thank you very much. But without taking so much time, I would like to acknowledge everyone's presence here. And thank you very much for using your precious time to come and celebrate our culture. We in Ngemba, we say that our culture is our identity. And that our culture is like your shadow. It follows you even in the dark. It sits with you. When the light comes out, it's following you. So without taking much, I would like to honor our special guests who have opened their arms to welcome us here in Lowell. We have seated here the Lord Mayor, Honorable Sokari Chow. Could you welcome the mayor, and his wife? Welcome the mayor's wife, especially. Could you stand up so that we give the honor? Well, it is in no order, it's just how the person who made this list made it, because all our guests are very, very important. I would also like to welcome, for us to recognize Councillor Rita Mercia. When you see her, she is one of us, and she welcomed, when she was mayor, she welcomed the front of Mancon. And you only need to look at her, then you will know that yes, she was welcomed by the palace. Next in my list, I'll have representative, state representative, Honorable Van Hau. And I will welcome you. Thank you very much.
She's our own.
Yeah, yes. Also, we have State Representative Radimon and his wife. Then we have also my very long time friend, who go very back with Mr. and Mrs. Shapiro, right here. You know, we say that we keep the best for last? All right, so would I say that I'd like also to introduce our former chief of Lowell chief of police and a very good friend, Mr. and Mrs. Lubali. So with all the humility that we in the Ngemba people bring in this city, and we really want to thank you graciously for opening your arms and make this city a second home, a home away for us, the Ngemba, and all the Cameroonians and Africans in this city. Thank you very much. We always say that if you want to travel around the world in 7 days, come to Lowell and spend 7 days. You would have traveled the world. That's the beauty of Lowell, and there is so much to love about Lowell. Thank you very much.
Thank you, Pat.
Constant break dancers. Author. Danger. Freak. Corner. Inward break same time. Outward break. Time. Author. And for
Children, God is in us. You must see that we are progressing on your sweat. You should not be progressing on someone's sweat. Why should you even stay behind with me? Whoa.
single roll. And double roll dancers.
Children, God is with us. You must see that we are progressing on your sweat. You should not be progressing on someone's sweat. Why should you even stay behind with me?
Swim left and right dancers.
Yeah.
Enjoy yourself.
Don't forget on someone's sweat.
Constant break dancers. Break and shake with them. Nice. And
Our guest has arrived, Dr. Nkimbang. Let's see if we can get her up on the screen here. It's Dr. Manka, is that it?
Yes.
And I'm supposed to do a quick intro, but you've got a long biography for such a young woman. So you're a nurse researcher and an assistant professor, University of Minnesota. Have you picked up the Minnesota accent yet?
Not yet. I still have my Boston accent or my Massachusetts accent.
So at the School of Public Health and an affiliate assistant professor at the University of Minnesota School of Nursing. And I'm going to cut through to the chase.
Isn't she related to Fru?
She was. I'm trying to protect her from that. So you went out to UMass Amherst and got your bachelor's degree. So that was good. You have a PhD in nursing from Johns Hopkins School of Nursing, a master's in public health from Boston University. That's all pretty impressive to me. And your research centers around understanding the cause of health inequalities in minorities and improving health outcomes for older adults. Yeah, I'm all in favor of that. So you're currently leading 2 projects with African immigrants in Minnesota, trying to understand African immigrants' dementia care, caregiving, and education experiences and needs. That's all pretty good. We had a slideshow. Does anybody have the slideshow? So, Doctor, give us a quick overview.
So your question again, Cliff?
Yes, put her on the screen, and we're looking for the slideshow.
Download the slideshow.
Okay. That's good.
That's going to take a little bit. I'll tell you when I'm done.
That'll be good. You can see the oppressive atmosphere under which we work here. The producer is in charge. How did you end up in Minnesota?
Good morning, everyone. Thank you so much for having me on today. I guess my journey to Minnesota is a long one, starting out in Cameroon, West or Central Africa, and then I'm sure you already know that there's kind of a civil war happening in Cameroon and Amazonia, so there's all of that. So that's a little bit of my history, going to primary school and boarding school in Cameroon and wanting to become a medical doctor while I was there, and then migrating to the United States as a teenager to join Dad when Dad had already moved out here. So I moved to Lowell, Mass to join Dad, and went to Lowell High School for a couple of years, and then did all of the things that you talked about in my CV, the master's, the PhD, and then really hoping to work in community. And as I was finishing up the PhD, a great opportunity came out to work with the African immigrant community in Minnesota, really to understand what was happening related to healthcare needs for older adults around dementia. And so I moved kind of to Minnesota to join my community partner to do that work.
Ah. Okay then, that sounds good. When you talk about the African community, are you talking about people from Africa, or do you also include people who have immigrated to the United States from the Caribbean?
So the term immigrant is typically referred to somebody who was born outside of the United States, and then we begin thinking about the bucket. So as an African immigrant, we typically have quite a few designations or kind of different ways of talking about African immigrants. So we have the first generation African immigrants. Those are people like myself and Dad, Mr. Fru Kimba, who were born in or on the continent of Africa and then migrated to the United States. And then we have, that's the first generation of African immigrants. And then we have what is called the second generation of African immigrants, who are the people, kids or children who were born to parents in the United States, but whose parents were born in Africa. And that is very different from the African Americans, which is typically the descendants of slaves in the United States. And that is also very different from Afro-Caribbean, who are the persons of African descent who were born in the Caribbean islands. And so with the Afro-Caribbeans, you have the first generation who were people who were living in the United States, born on the Caribbean islands. And then we have the second generation who are also people who were born in the United States, so children of persons born in the Caribbean islands.
Okay. We can't get your slideshow up. Can you share the screen and put the slideshow up at your end and talk to it?
Yes, sure.
Okay.
1 second. I can download that.
That'll be good. So, do you get out to Minnesota often, Fru? Oh, you do?
So, I'll ask Fru, what caused a lot of people from Africa to immigrate to the state of Minnesota? I mean, we have all kinds of areas in the United States. What attracted them to go to Minnesota?
I don't really know. I can only speak for the Northeast here in Massachusetts in particular. Most of us who came here, we came in, for education, and most of us who are here, we got our admission into universities here all the way from Africa before we came. So our foundation was already laid in Africa. Then we came here to continue our education. So as the trend has changed, in Minnesota, I don't know, but wherever there is a concentration of the immigrant group, they have new arrivals always gravitate towards where they would be welcomed by their kinsmen who are already there. So I would think that it's because one reason could be that there were many Africans who were in Minnesota, and the new arrivals also go there because they would easily acclimatize and settle with the community.
Okay, I think we're ready for the slide presentation.
I can add a little bit to what Dad has talked about since I'm a Minnesota resident now. And so basically, we typically find that there's kind of like 3 buckets of reasons why there's a lot of people migrate. So we have the people who are migrating, like Dad was talking about, for economic opportunity. So people looking for jobs, people furthering their education. And so we have a huge generation of immigrants that came to the United States for that. And then we have another group that is persons that are migrating because of civil war and other kind of things that lead to refugee and asylee status. And so we have people who are being brought together by the Refugee Commission. And those persons often are settled in states and countries that are open to accepting them. So we find that a lot of the East African immigrant population in Minnesota, they've migrated as part of the Civil War refugees to the United States. And then we have another bucket of immigrants that migrate due to family reunification. And so that's persons who had come to live in the United States are now requesting for their family members to be brought here, or also persons who are migrating through the visa lottery program. So that's another bucket. And so those are some buckets of how we get a lot of African immigrants and other immigrants from different parts of the world into the United States.
Oh, good. We're ready for the slides.
Sure. Can you all see the slides now?
Yes.
Yep.
Perfect. So I talked a little bit about my roots, and I would maybe just take this moment to talk about how I got into the research with older adults or research in general. And so when I graduated from UMass Amherst, I was working at Lowell Community Health Center, and I was kind of witnessing a lot of difficulty there. I would see a lot of persons having to choose between buying their medications for diabetes or buying dinner. And so that's kind of when I began thinking there needs to be something that we can do, or there is something that we can do to improve health of older adults. And at that time, I was thinking maybe policy change can improve the health of a community, can enable people to get a good dinner and also buy their medications. And so that's how I found myself to Boston University to study health policy. And while I was at Boston University, I had an opportunity to work on a research project. And that project was the 40,000 clinical trial that was happening in Zambia. And during that time, I witnessed how what informs research or what informs policy is actually research and quality evidence from research. And so when I graduated with my master's in public health at that time, I figured, all right, I'm going to go work on research projects that are targeting health policy. And so as I began I moved to Baltimore at the time to work on a research project with older adults that was helped at improving a CMS policy around staying at home and aging in place. And then as I was working on that project, I realized that the persons that were in that kind of bucket of group were persons that were old, were people who were very challenged. And so I began looking at the African immigrant community because I am part of the African immigrant community. And I go out to community-based organizations and I see a lot of older adults who were suffering from similar challenges that I was helping US-born older adults deal with. And so I began thinking maybe I can use what I was learning in that policy-informed project to help in the African immigrant community. But then my mentor at the time asked me, what is the evidence? How many African immigrants are living in the United States? How many African immigrants are suffering from the same issues that we're working on this project? How many African immigrants have physical function? How many African immigrants have dementia and all of those things? And so I began looking at the data, and I could not find anything on the African immigrant population, especially the older adult population, which is how I then realized that if I'm not the person gathering this data on the community, we might not have any data. And so that's one of the reasons how I went into research and research for older adults, older African immigrants in particular. And so in the slideshow, I'll talk about two of the projects that we're working on in Minnesota to explore kind of dementia care needs for African immigrants. And so the first one is the African Immigrant Memory Loss Project. And this project, I don't know if you all are familiar with the term community-based participatory research project. It's a method where the researcher works with the community and in the community to do a project. And oftentimes, in this approach of research, what is encouraged is that the question or the need arises from the community and not the researchers. So the community is supposed to really identify what they need in terms of research, and then they're supposed to work together with the researcher to really identify those needs or solve that problem that was identified. And so for the African Immigrant Memory Loss Project, which its goal is to develop culturally informed instruments and then use these instruments to collect data on dementia care needs, knowledge and resources, what happened is that our community partner, ASA, and ASA is African Career Education and Resources Inc., began noticing that there was a lot of challenge in the community related to dementia care for African immigrants. And so they approached my mentor at the time, Dr. Joe Gogler at the University of Minnesota, and they said, we've noticed this need. Your expertise is dementia. We are community members. We really do not know what to do. How do we understand this in a more systematic way, not just in the kind of dotted way that we're seeing it in community X and community Y? And so at the time I was finishing up my PhD and I was looking for kind of the next things. And so my mentor put together a group including ASA and myself to apply for a grant so that we can fund this work. And so we got the grant. So this project is funded by the University of Minnesota Program in Health Disparities. They gave us a small grant to work on this project. And so once we got the grant, which was summer of 2019, we really began thinking about how do we do this project in a way that is equitable. So it's not that the researchers are powering the project, but it's an equal partnership between the researcher and the community. And so we decided to create this model, which is a threefold model. So we have the community partner, which is ASTA, the staff and the interns, working together with the university research staff and team and volunteers. And then we created a project advisory board, which is made up of 20 members in the community. And so we now began to do the project in August of 2019. We started by having community conversations. We held about 5 community conversations, asking people, what have you seen? What have you heard? What do you know? And then we got that data and we used it to create a survey that we then implemented in the community. Back again in the community, went out to churches, mosques, community-based organizations, and administered the survey there, and we also did it online for people who are very tech savvy. And so we implemented that project and we finished that project in March of this year. And then while we're doing this project, we had quite a few people at the community conversations coming to us as a research team, telling us, we already know that there's a need for dementia education in the community. Nobody knows what dementia is. Nobody knows how it manifests itself. Nobody knows how to manage it. Why are you doing a research project now, asking us questions when you already know what the need is? And so that's when the next project was kind of born, which is the African Immigrant Dementia Education Project. And so the goal of this project is to develop a culturally tailored dementia education for the African immigrant community. And so that project was started about the fall of 2020, a year after the initial project. And so we'd use the same leadership model since we found out that the model was working in the past with the other project. We're working in partnership with our community partners, and we also have a project advisory board. And we've now developed a dementia education program that we're just about ready to launch in the community. And we're hoping to really help people understand kind of the needs around dementia in the community and also provide resources. And then as we began thinking about the projects, we had 2 projects already lined up, and we have more projects in the pipelines. We have a couple of grant applications that are out for different projects. We realized that we cannot keep naming each of our projects by its unique name, the African Immigrant Project, the Dementia Education, the Memory Loss, and so the names are going to become too many for anyone to remember. And so last summer, it was voted by our board and the entire research team that instead of calling each of our individual projects their unique names, we're going to just have a group name, which is called the Immigrant Memory Collaborative, to really capture all of the projects that we're working on related to memory in the community. And I wanted to highlight the methods that we're using. Again, as I mentioned, it's a community-based participatory research approach. So we have project advisory board meetings, and what we do at these meetings is really have a consensus style of agreement, making sure that everyone's voice is heard. We take notes at these meetings so that we keep track of what we're doing. We're having conversations in the community, asking people to really share their own personal experiences. We're conducting surveys, and we're also talking to individuals for 2 to 3 hours in key informant interviews to explore kind of what they know, what they're doing, and how it's affecting them personally. And then, like I mentioned, this work cannot be done without the whole team, the village. We have our participants, we have our project advisory board members, we have our volunteers. Again, a lot of community members have volunteered for these projects, both from our community partner and also from the university. We have a lot of undergraduate students at the university who are volunteering for our work. And then, again, all of this work would not be possible without some of the groups that are funding our work, which is the chair, Robert L. Kane Endowed Chair at the University of Minnesota, and Johns Hopkins Alzheimer's Resource Center, University of Minnesota Program in Health Disparities, and the Minnesota North Star Geriatric Workforce Enhancement Program, which is SQUARE. And I wanted to just share highlights of this. I know you all will have questions about kind of what we found, what the results are, and what we're going to do with some of the data that we found. But I'm just going to stop here and then welcome on any and all questions that you have for me. Thank you.
Okay, that's a good summary. Lack of data has always bothers me. I like data as a way of understanding. Who's that? Lord Kelvin says, if you can't measure it, you don't know what it is. So, it's information. Have you been in contact with the U.S. Census Bureau to see if they can help or if they're interested in what you're learning?
So, the short answer is not yet. And because what happens is the Census Bureau actually has a couple of projects that are collected related to census data collection and census tracts. But what often happens is that we don't get a lot of immigrants into that data set. And so there is a data set, there's quite a few national data sets. One is the National Health Interview Survey that collects data. So the first thing is that we don't have a lot of immigrants in this national data set. And there's a couple of reasons why we don't have a lot of immigrants in it. The first one is that immigrants typically reside in multi-generational homes and in ethnic enclaves, and so the way the census does the sampling is tricky because it might not capture the way immigrants typically reside, and these are cultural norms in which immigrants stay in homes with the parent, the grandparent, and then kids, and even quite a few generations in homes. And so the way data is often collected in some of these data sets does not capture that. Secondly, there's kind of cultural issues where people come from countries where there's no research and there's no data, so they don't understand what data is. And so if somebody approaches you at your door trying to gather data and you don't know what research is and what data is, chances are you're going to say no. And so then your voice is not counted in those data sets. And then the last aspect of those, the limitations of those national data sets is that typically, to make it very easy and capture general information, they don't ask a lot of specific questions. So when we're thinking about a disease or medical condition such as dementia, the way it's captured in many of the large data sets, it's in 2 to 3 questions about memory. But dementia is much, much more than memory. And so we're limited in the way it is actually being measured. And we as researchers cannot do much with a limited measurement in those data sets. And so oftentimes we actually have to go and do a unique research project with whatever group we're interested in to measure it in a targeted and more valid way.
You said dementia is more than memory. In my mind, dementia is a problem not able to do put things together as well as lots of memory. How do you define dementia?
So, dementia is an umbrella term for quite a few diseases, and dementia really is caused by brain death, and there's so many reasons that can lead to brain cell death. And what happens is the symptoms or the challenges that you find you have, or a person with dementia has, are related to where there's a problem in the brain. So if memory brain cells are dying, then you have a problem with memory. If critical thinking and judgment are affected, then you have a problem with critical thinking and judgment. And a challenge with critical thinking and judgment could be somebody trying to go to the bank to get money and walk into the bank and forget what the bank is and what they're supposed to be doing. So basically, dementia is an umbrella term for a lot of diseases. You have Alzheimer's dementia, you have vascular dementia, you have Lewy body dementia, and those have different unique causes, but all of it leads to brain cell death that then affects cognition, judgment, affect, mood, and a lot of things that the brain normally controls. We all know that the brain controls a lot of things, a lot of processing, and a lot of things that we do. So if there's loss in any brain cell function, that then affects the symptoms that a person with dementia is going to witness or recognize. Or the family members, the person with dementia at times does not even recognize the symptoms. It's the relative who is living with them and dealing with them that's going to say, oh, mom is actually behaving differently. Dad is behaving differently. My brother is behaving differently. And so that's kind of what dementia is.
Have you found any groups that don't have this dementia, don't suffer from, say, Alzheimer's?
So we haven't found any kind of groups that do not have dementia. What we found is that African Americans or blacks have double the risk of dementia, and Hispanic or Latino Americans have 1.5 times greater than white, the risk of dementia. But as far as we know in the literature, all races, all groups of persons have a risk of dementia. And so it just depends on what kind of dementia and what your unique risks are, and even your lifestyle and all of that good stuff.
Yeah, I'm familiar with dementia because my mom, who's 90, has dementia. She's in assisted living in a full 24-hour care facility. And we saw it coming, for the last 5 years. And it's unfortunate, but I know they're doing more and more new research on looking at Alzheimer's and dementia. I guess they've finally isolated the protein that is causing some of dementia, and I read that there's going to be a new blood test on the market next year that might be able to predict whether you're going to have Alzheimer's or dementia, that you can have early intervention with treatments for.
Yes, that's really the exciting news, because for the longest time, the research on dementia was kind of really stalled, but we're excited. The research that you're talking about came out of Mayo, saying that there's this new blood test that could really help with diagnosing Alzheimer's related dementia. And so that's something that is very exciting, and we're looking forward to hopefully having a couple more projects and more studies support that particular claim, and then going from the research into practice, which is where we really see clinical effects once it gets from research into clinical care.
I think the biggest impediment, whether it's the group that the African group that you're doing research on, or any other group, is being proactive to educate people on lifestyle, diet, and also being made aware of this new research that can prevent what's going on. I think that's the biggest problem in a lot of communities, is that the people are not aware of what can be done. And I believe that's what you're working on mostly, is, if you're not aware of it, how do you know how to prevent it? So.
Yeah, that's definitely one of the biggest challenges, especially in many communities. Yes, unless you have a family member or relative who had dementia, you really do not. You can know the terminology, but you do not understand what it means for someone to be living with dementia, and especially to then be able to recognize how to help that person. And like you're talking about, Mike, there's so many hurdles with the healthcare system on just being able to pick up the symptoms that a family member is dealing with, and then going through the process of assessing and then getting a diagnosis. Do you mind me asking how your family got a diagnosis? Tell us a little bit more the process.
Yeah, sure. So we saw my mom starting to have issues with memory, repeating. We saw it starting to go over the years, because my parents are both 90. We visit I have two other brothers and a sister, and everybody would visit on a regular basis. So we got together, and I was mostly taking my parents for their medical appointments, all that kind of stuff. And we noticed that, and so we had my mom evaluated. And that's how we got the dementia diagnosis with Alzheimer's. And then we took more proactive steps. Actually, my dad's doing okay, but we had him evaluated also. So we have a baseline. And that's what I'm talking about. People don't realize the things that can be done to be proactive.
Can you talk more about evaluation? Because I don't think a lot of people understand. Was it just like you went in and got a blood test, like for diabetes, and then they gave the diagnosis?
Well, there was numerous things. There some blood work done, and then there was an evaluation test and we actually went to a doctor who deals with Alzheimer's and dementia. So they evaluate on your daily living activities, on what you're capable of doing. Like my mom couldn't do finances. We noticed that. So that's one of the things they evaluate you on. They also ask things like, do you know where you live? Can you identify certain animals? There's a test that it's like 20 questions. That's only part of it. You know, I know they made a big thing with Trump taking his test. He passed it. Well, I was there when they did the test. That's only one part of it. You know, there's other things that they do, and that's what I'm saying about being proactive and being aware. Because we talked to her primary care physician, and she's the one who ordered some of the evaluations when we saw it. And I just think people put it off as, well, you're getting older, you can't remember things. And it really isn't that. There's a number of things that are happening. And it's subtle. It doesn't happen like today you can do it, and tomorrow you can't. So it's something, if the family is paying attention, you can see it. But if somebody's living by themselves, they don't have friends and support group, then it can happen, and all of a sudden you're like, how did those people get like this? And I think that's more what you're talking about, trying to be more proactive and making people educated so that you can get to this earlier and help people.
Yeah, let me ask you this. In your research, have you noticed a difference in minority health between immigrants and their U.S.-born counterparts?
There are definitely differences in health, and it really depends on what generation of immigrants you're talking about. So basically, what we find with a lot of the first-generation immigrants when they first migrate to the United States is what we call a healthy immigrant effect. So in some ways, they are typically healthier than their US-born counterparts. So if you're thinking about African immigrants and African Americans, so these are the Black population, you find that the African immigrants who recently came are healthier. And there's a lot of reasons for this, because the process of immigration itself, it's very, very difficult on the person's brain. So we have, for the people who are migrating, not because of civil war or kind of migrating in search of better opportunities, you actually need to be able to be really healthy to undergo the process of traveling. So if you're thinking of an immigrant, let's say from Cameroon, there are some villages in Cameroon that you have to travel 3 to 4 days from that village to an airport to migrate to the United States. So if you're thinking of traveling, you need to have the financial resources, and you need to be able to be healthy enough to do all of that travel and going through the whole process. And so in some ways, it's not surprised that the immigrants that we're seeing here are healthier, especially for those who are migrating voluntary, because the journey itself already requires health. Then, for the persons that were non-voluntary or involuntary migrants that are coming because of civil war, we often find that they are coming with a lot of trauma, civil war trauma, violence trauma, and all of those things. And so their health, especially mental health, is really, really bad. But what we find that as soon as immigrants start living in the United States for about 10 years, their health starts changing, and it's kind of narrowing, and now they have similar health outcomes, so that by the second generation, the health outcomes are just similar to those that are born in the US. And so even if an immigrant migrates while they are healthier, they typically come here, and then by the time they stay here longer, they're losing any benefits that they might have had. And for those who have any trauma, violence, civil war, any of those things, it also gets a little bit worse as they stay here, because some of those memories are even repressed, and then as they get older and other things happen, things start showing up in very different ways. And then I just wanted to go back to something Mike was talking about to clarify about the process of diagnosing dementia. Again, we really do need to educate our communities, because that process for some people can take years, depending on access that you have. So like Mike was saying, it starts with your primary care doctor, and that's if you have a primary care doctor. So we have a lot of immigrants who do not have primary care doctors. So that's a challenge. And so if you do not have a primary care doctor, you can't even begin to get in to access the basic blood tests that need to be done, to access some of the neurocognitive testing that need to be done. And then once you get that done, you're referred to a specialist, typically a neurologist, a neuropsychologist, others, geriatric internists, depending on who's specializing in what kind of dementia that's been suspected. And then you go through this process of assessment, again, months, MRIs, different kind of imaging tests that have to be done. If you do not have the funding, the resources to go to all of those appointments, if you do not have transportation, if you do not have the family support to get all of those things done, it can be challenging. And so some of the things that are basic for some groups might become really challenging for other groups that have like challenges. For example, in Minnesota, we have rural Minnesotans that do not even have a neuropsychologist within 100 miles of where they live. And so if you're living in a rural setting that has, and your family is worried about you having dementia, you can go see your primary care doctor if they're even close, and then it might take you a lot of planning with your relatives to be able to plan time to drive whatever 100 miles, how many schedules you have to coordinate. And so that's where some of the challenges in accessing care come. And if people do not recognize that these things are happening or have to happen to get a diagnosis, we're not prepared. And so that's some of the work that we're doing related to really help people understand what the disease is, what the diagnosis process is, not to even talk of what the treatment options are.
I did have a question from someone. Are there any exercises you can do to keep your brain healthy as you get older? Any activities you can participate in?
So, a couple of the risk factors for dementia are behavioral linked. So, obesity has been known as a risk factor for dementia. Diabetes and hypertension, which also have like diet and health lifestyle issues, have also been noticed as risk factors for dementia. So whatever you can do to limit or reduce your risk of diabetes and obesity. So physical exercise is a good thing. And then a lot of research is showing that social and cognitive engagement also helps. So doing puzzles, things that stimulate your brain and memory, are also helpful and also recommended. Sudoku, all of those kinds of things. Websites such as the Alzheimer's Association website often have a lot of those educational materials. AARP also has quite a few educational materials, so people can access some of those materials from there. They have quick puzzles, word games, and all of those things that you can do to stay cognitively intact and just keep boosting your cognitive function. Yeah.
I saw the biggest decline in my mom because of COVID, because everything was shut down. They had no social interaction. And it's not just her. I mean, it's affected a lot of people, in a lot of ways. So I'm very aware of what you were saying.
Yeah, there's a lot of research that's saying that social isolation is also affecting memory. And again, a remedy for that is doing what you can to stay socially connected. In times of COVID, maybe hanging out over Zoom, doing whatever you can with family members. If you are relative to an older adult, just stay in touch, contact them, reach out as often as you can and engage them, engage in games, puzzles, really try and work in to keep persons, especially the persons living with dementia. A lot of people think once you're diagnosed with dementia, then it just goes downhill. There's a lot of work that needs to be done. And that's what we're finding, that a lot of older adults were dying during COVID related to just being isolated in those facilities that they were residing in, is because there was no contact with the outside world. And so we as family members of persons who are living with dementia really need to continue engaging them in as much as we can in various activities of daily life. If the person can still do just a little bit of breakfast prep, help them, support them, do that. Don't just go in and start doing everything. That really helps makes everything worse, because they stop doing whatever they can and then just depend on you to do it, which is not good for their cognitive and physical function. So if you're a person or you have a relative that is living with dementia, take the time. It takes much more time to be able to involve them in different things. So just schedule the time to be able to involve them If it's bathing and dressing and grooming and eating, it's just going to take a little bit of time. But that time engaging with them and involving them in those tasks is very, very important for their own well-being.
Okay, so we've got to go because we have to send your father off to work to get him mental stimulation. But I really appreciate you coming on and talking about this. And at some future date, if you have new information, please feel free to reach out to your father and we'll get you on again. Thank you.
Yeah, thank you so much. Yeah, it's great information, and it's very unfortunate that people aren't being treated early enough, but I think things are looking good on the horizon, though.
We're gonna go. We gotta go, Mike. Thanks.
Bye.